Yeah, so I appreciate the opportunity to be here, and thank you for having me. It's nice to be able to highlight the CME program we held this year at the 2024 LUGPA Annual Meeting. I think some of the highlights would be one of a couple. There's been a tremendous amount of opportunity and development of new therapeutics in the realm of bladder cancer. Dr. Tom Jayram gave us a wonderful overview of, I think, some high-level data looking at the management of patients with high-risk non-muscle invasive bladder cancer. I gave us some forward-looking thoughts on folks with newly diagnosed renal cell carcinoma. Additionally, we had some fantastic presentations by Dr. Scott Eggener, as well as Dr. Ronney Abaza, both on one from Dr. Eggener dealing with new technologies in the management of patients with prostate cancer. Again, forward-looking, understanding what some new technologies, both from a diagnostic and therapeutic perspective, might entail in this patient population. And from Dr. Abaza, looking at new technologies from a robotic surgical perspective, which can further improve our patients' quality of care and outcomes who are undergoing minimally invasive surgery for their prostatectomies. With the rapid growth of new therapeutic options for patients with bladder, kidney, and prostate cancer, requires us in the community to develop infrastructure to support not only the development and widespread adoption of these therapies, if applicable, in our patient populations within our practices, but also we need to make sure we're doing this kind of thoughtfully and safely in the appropriate patient populations. Educational needs, really this should be, in my opinion, a champion-based system where we're identifying physicians who deal with these patient populations on a continual basis, because many of them are high risk, and high risk not only for disease progression, but for disease death. We find that identification and consolidation of care in these patient populations improves the outcome and improves the likelihood that they'll get treated appropriately and by guidelines-driven medicine. Educationally, I think it helps to reinforce some of the novel developments of therapeutics in patients with bladder, kidney, and prostate cancer. Bladder in particular, as well as renal cell carcinoma, in the not too distant future, are going to have an explosion of not only new therapeutics, but new diagnostics. Meetings like this, regional meetings of LUGPA, as well as sectional meetings of the AUA and the main AUA meeting, are great places to educate our membership around new and novel therapies. So PSMA PET arguably has been one of the biggest inflection points in the appropriate staging of patients with advanced prostate cancer, or I should say prostate cancer in general, in the last 30 years. It's allowed us to much more accurately stage patients, and allows us to really consider two important concepts. One, the concept of treatment intensification, and the other, treatment de-intensification. That being, in the patient who requires more aggressive therapies, we can do so more appropriately based on image-guided endpoints, and conversely, in those patients, to avoid overtreatment and intended potential morbidity associated with that therapy. So it's really been, I think, paradigm changing for this group of appropriately staged folks with grade group 3 or higher disease, those patients with biochemical recurrence, or those patients with hormone-sensitive metastatic prostate cancer. Additionally, it's allowed us to develop a class of theranostics, which is going to be a targeted therapeutic based on PSMA positivity in patients with advanced prostate cancer. Again, another line of therapy to extend life based on the LU177 data in patients with castration-resistant metastatic prostate cancer. So from an IO use or immunotherapy use in early stage bladder cancer, depending on what you mean by early stage, we have patients who are BCG refractory non-muscle invasive disease. There's a current IO approval in pembrolizumab in that patient population with a 12-month CR around 19%. With the intended kind of normal toxicities we see associated with immunotherapeutic use, for the most part, very reasonably well managed in the 0.3 to 1% range. As these therapies move kind of from right to left, meaning to patients who have high-risk non-muscle invasive disease in the BCG naive setting, BCG already provides a very high bar as a very good therapeutic, with 12-month response rates in the 70% range in most kind of reports. So the addition of an IO in this patient population in a non-life-threatening situation is really going to have to demonstrate significant incremental improvement over that BCG alone outcome. What that incremental improvement is going to be required to receive widespread adoption of an immunotherapeutic in non-muscle invasive high-risk BCG naive patient populations, I think, is probably an ongoing conversation. But we'll see some readouts of some of these trials in the not too distant future. CREST trial being one, Potomac and Patapsco being two others, which will give us an insight into the response of patients with a BCG naive high-risk non-muscle invasive disease. So I think from a therapeutic perspective, the future is bright, but we have to make sure that we're able to identify and manage attendant toxicities, and that I think the improvement in complete response rate has to be fairly significant for to have widespread adoption in this patient population. When we look at novel approaches in the next 5 years to reshape geo-oncology landscape from patient management and diagnostics, I think there's a couple of things. One, development of additional markers. We had talked a little bit about high-risk non-muscle invasive bladder cancer, those patients with whether it's the BCG naive setting or the BCG refractory setting, developing markers. We have one already in intermediate risk patient population, FGFR, and that expression is tied to that disease state. We have a therapeutic to target that, and the responses have been pretty favorable there. So I think ongoing development of gene-based risk stratification and application of appropriate therapeutics in the appropriate risk stratified patient based on their genomics is going to be really a big opportunity to change the way we manage patients with bladder cancer, whether it be DNA-based and prediction models to understand who is going to be BCG responsive versus not, whether it's the ctDNA analysis in the muscle invasive patient post neoadjuvant chemotherapy and cystectomy, for the addition of adjuvant therapy in the high-risk patient population. Additionally, there's going to be some novel imaging modalities, specifically in renal cell carcinoma. We're going to be looking at some new advancements in the ability to very accurately diagnose renal cell carcinomas much more precisely with use of PET imaging, which heretofore has been unable to be accomplished. So I think more accurate diagnosis in both bladder and kidney are on the horizon.